What's up, you guys? Today we will talk about renal stone. So renal stone, how does that present? Usually present with colicky flank pain, radiate to the groin with hematuria. Okay, colicky. Let me zoom it a little bit. Colicky flank pain, radiate to the groin with hematuria. So what do we do after that? We do UA. Okay, so if the UA came back positive for microhematuria, we look for microhematuria. If it's positive for microhematuria, what do we do after that? Then this is a stone. So what we do non-contrast CT. Non-con CT, okay? What happened? Okay, non-con CT. Non-con CT scan, what do we do? Now it's going to tell us the size of the stone, okay? After that we look if we assess, is there any stone? Is there any hydronephrosis? So we look at this, is there any of that, okay? If it's positive, then we go to the management of stone. We're going to talk about it based on the size. If it's negative, then look for something else. Negative, something else. The CT scan said it's not. Okay, for microscopic hematuria, let's make it better. So microscopic hematuria positive, okay? Now, what if it's negative microscopic hematuria? Let me make it this way. Microscopic hematuria here. If it's positive, I'm gonna add it here. If it's negative, what do we do? If it's negative, then it's not a stone. Not a stone, okay? So now let's say it's positive and we found the stone. What do we do after that? Now we're gonna, based on the size, general overview, the treatment. Let's go here. Let me put it here. Treatment. General overview. Excuse my spelling. General treatment. So the general overview is that if it's less than 5 mm, we do IV fluid and pain med. Okay, if it is more than 3 cm, then we do surgery. Okay, if it's in between, then we do lithotripsy. This is the general overview, but let's go detailed management. Detailed management. Look at it. If it's less than 5 mm, or if it is less than 7 mm, it's going to be different. Or if it is 7 mm to 1.5 centimeters, it's going to be different. If it is more than 1.5 centimeter, it's going to be different too. So okay, so we have 4 measurement. That's an accurate measurement. If it's less than 5 mm, same thing as we said, IV fluid plus pain meds. Okay, if it's less than 7 mm, then we give medications. For example, calcium channel blocker or alpha blocker. If it's 7 mm to 1.5 cm, you want to break it. Okay, how do you break it? Based on the proximity. If it's proximal, then you do lithotripsy. If it is distal, then you want to do ureteroscopy, because make sure distal closer to the urethra, that's a ureteroscopy will reach it. What if it's more than 1.5 centimeter? This based on the if it's septic or not. Is it septic? If it's not septic, then you look at the, is it proximal, then you do laparoscopy, or if it's distal, then you do PAN, which mean pericutaneous anterograde nephromyotomy. Okay. What if it is septic? Yes, if it is septic, what do? It's gonna be different. If it's proximal, we do nephrostomy. If it is distal, then we do stenting. Okay, so that's basically a summary of the stone management based on the size. In a simple form, less than 5, IV fluid and pain medication. If it's less than 7, we give some calcium channel blocker and these things. If it's more than 1.5, if it's septic and distal, stent. If it's not septic and distal, ureteroscopy. If it's septic and proximal, nephrostomy. If it's not septic and proximal, laparoscopy. These are the manner. Now we look at the types of stone. What it could be, so you can so that you modify the risk factors. Okay, you screen them after 6 weeks, and then you see this could be calcium oxalate stone. That's the most common, 80% of the stones. Usually it could be opaque, and risk factors usually calcium and oxalate from its name. How do you manage it? You can give thiazide, and you can decrease oxalate and increase citrate. This is the management in the diet. Or it could be the struvite stone. If it's struvite, usually it's opaque and caused by Proteus, and we usually do surgery for it. Okay, and antibiotic. Or it could be uric acid. Usually it's lucent, gout, tumor lysis, and we treat it by allopurinol and rasburicase. Okay, if it's cystine stone, then it could be it's lucent, caused by genetic. So you gotta modify like it's genetic disease. So this is basically this is the most important thing you gotta know. Just to recap, calcium oxalate, 80% most common. You decrease oxalate, increase citrate, give thiazide. That's you should know. And the management of a stone after present colicky, flank pain, radiate to the groin with hematuria. You look at UA, you do, and then you do non-contrast CT. After that, you find the sizes. Less than 5, IV fluid, pain med. Less than 7, calcium channel blocker or alpha blocker. If it's between 7 and 1.5, if it's proximal, the lithotripsy. If it's distal, the ureteroscopy. If it's more than 1.5, look at the septic. If it's not septic, proximal, laparoscopy. If it's not septic, distal, pericutaneous anterograde nephromyotomy. If it's septic and proximal, nephrostomy. If it's septic and distal, stent. And this is the management of a stone. Thank you for listening.